Hi everyone. In this presentation, we are going to talk about root resorption. We're going to discuss the etiology, the pathology, how to diagnose this condition, and how to manage it properly. So let's get started. Now, dental resorption is defined as the progressive loss of the dental hard tissues as a result of clastic cell activities. Um, this resorption can be a physiologic normal process if it happens in the primary teeth, or it can be a pathologic process if it happens in the permanent teeth. You would expect root resorption to take place in the primary dentition, and this is a normal process that results in exfoliation of the primary teeth. But if tooth or root resorption happens in the permanent dentition, then this is largely a pathologic, irreversible process, and something has to be done to stop it and treat it. Okay. Now, we all know that microorganisms can invade the root canal system via cracks, caries, defective restorations. This bacteria can gain access to the root canal space and will cause pulpal inflammation. And if this left untreated, the pulp can undergo necrosis, and the infected necrotic pulp will result in apical periodontitis. And apical periodontitis is inflammation of the periapical tissues surrounding the periapical area of the tooth. Apical periodontitis is manifested on radiographs as we see it as widening in the periodontal ligament space, and in more advanced cases you'll see loss of lamina dura, which is the compact bone lining the tooth socket. And if this left untreated, then you will see a large periapical area or a radiolucency on the radiograph, which represents the resorption of the bone in the periapical area, and that's where the body immune response is trying to stop the infection from spreading. So we usually see a large periapical area, and if we do the right treatment, this bone will regenerate, and eventually, if you follow your cases up, you will see healing and regeneration of the periodontal ligament space and the lamina dura and the cortical bone. However, you rarely see this or this. You rarely see that resorption is taking place in the root material itself or in the dental hard tissues. We usually see the resorption taking place the bone surrounding the tooth, but not in the root itself. Okay? Have you ever asked yourself why? Now, here's the answer to your question. What makes the root more resistant to resorption when compared to the bone surrounding the tooth is the following. So let's have a look at a cross section in the root of the tooth. So you have the dental pulp protected by the dentine and the cementum, and then the periodontal ligament, and then the bone. Okay. If we have a closer look, you'll see that the dental pulp, the outermost layer of the dental pulp is the odontoblasts. The odontoblasts have processes that extend into the dentine. These odontoblasts, they function or they produce dentine or the predentine, which is the unmineralized, the first layer of dentine. It is unmineralized. This layer will move away from the dental pulp and will become mineralized, forming the dentine proper. And then in contact with dentine, we have the cementum, which is the mineralized cementoid. And then we have the pre-cementum that's produced by the cementoblasts. The cementoblasts will form the pre-cementum. The cementum will become mineralized, forming the cementum. The cementoblasts, as they form the pre-cementum, they move away from the tooth towards the periodontal ligament. okay? While the odontoblasts, when they form the predentine, they move towards the dental pulp, okay? Now, you have noticed that these mineralized tissues, the dentine and the cementum, are sandwiched between unmineralized or non-mineralized tissues on both sides. And that's the secret. These mineralized tissues are not, they can be resorbed, okay? But what protects them from resorption is the non-mineralized or are the non-mineralized tissues surrounding them on both sides. These mineralized tissues will have a protein or a sequence of peptides, arginine, glycine, aspartic acid, the RGD sequence. And this sequence is, if becomes exposed or if there is any damage to the non-mineralized tissues protecting the dentine and the cementum, this peptide sequence will become exposed and it will attract the odontoclasts or the cementoclasts, and the resorption process will start, okay? So what makes the root or the dentine and the cementum resistant to resorption are the non-mineralized predentine and pre-cementum. If any damage happens to the pre-cementum or the predentine, then the mineralized tissues will become exposed, the RGD peptide sequence will become exposed, and odontoclasts will be attracted to the cementum and dentine, and the resorption process will start. Okay? Let's have a look at the osteoclast or the odontoclast, or in general any clastic cell. These are highly motile cells, which means that they can move easily above the bone tissue or the mineralized tissues. They are multinucleated giant cells. They result from the fusion of monocytes and macrophages. Upon contact with mineralized tissues that contain the RGD sequence, they will anchor themselves to the mineralized tissue by means of certain proteins, the integrins, and then they will create a small microenvironment which is, and start secreting acids, the HCl acid, resulting in then they will start dissolving and resorbing the mineralized tissues. Okay, they have a ruffled border, form a Hauschep's lacuna, which is the microenvironment in which the resorption process takes place. Okay. So in order for root resorption to occur, we need two things to happen: damage to the non-mineralized protective tissues covering the external and the internal root or surfaces of the root, and we need continuous stimulation. So if this damage was just a transient and there was no stimulation, then the process will arrest. But if there was continuous stimulation, in other words, if there was pressure by an impacted tooth or by orthodontic forces, or if there was an infection in the root canal or inflammation, then the resorptive process will progress. So two things to happen: damage to the predentine and the pre-cementum, which are the protective layers for the root surface, and we need continuous stimulation by pressure, infection, or inflammation. Then root resorption will occur. Okay. Now, root resorption can have different types or two types depending on the surface of the root on which it takes place. So if it happens on the external surface of the root, then it is external root resorption. If it happens on the internal surface of the root, then it is internal root resorption. or sometimes you can have both, which is a combined type of resorption. Um, and each of these will have subcategories. We have for the external resorption, we have the surface, the inflammatory, the replacement resorption, and the cervical resorption. For the internal resorption, we have the surface, inflammatory, and replacement. Now, we can give, for example, if you want to describe the resorption on this premolar, you can say that this tooth will have an internal inflammatory resorption in the middle of the root canal. It is extensive, especially on the distal side, and there is no periapical area or radiolucency. So you can add extra information describing the site of the resorption, the extent of the resorption, and whether there is a concurrent periapical disease or not. Okay. So let's discuss and describe these categories. It's very important to know how to diagnose these conditions and how clinically and radiographically, and how to manage them. Okay. So for the external surface resorption, it is a small, superficial, shallow resorption cavity, especially in the cementum and sometimes in the outermost layer of dentine. It happens as a result of localized damage or injury to the root surface, for example, subluxation or concussion injury, or any damage to the surrounding periodontium. This process is largely self-limiting, so it will heal uneventfully with new cementum, so no need for intervention. The patient will not have any symptoms, so it is a subclinical condition, and you can find it as an incidental finding on radiographs. It is unlikely to be seen on radiographs, but sometimes you will see a change in the contour of the root surface or a shallow cavity in the cementum and the dentine. But as you can see in this radiograph, the lamina dura is intact and the bone is intact. There is no resorption in the bone. It's just a minor alteration of the root contour. Now, if you diagnose this condition, no need for intervention. You just need to monitor it and see if there is any progression. So it's self-limiting, no further stimulus. It's just a transient or limited damage to the periodontium or to the root surface that resulted in this minimal external surface resorption. Now, if there was prolonged stimulus by infection or pressure, and the damage to the root surface was severe, then external inflammatory resorption will take place. So the patient, for example, will have trauma to the root surface, especially with luxation injuries, avulsion, intrusion, extrusive luxation, or lateral luxation. So the root surface will be damaged. The cementum and the periodontal ligament will be damaged, therefore the dentinal tubules will be exposed. Sometimes there are cracks in the crown itself, resulting in bacteria invading the pulp space. The pulp will become infected and necrotic. The bacterial byproducts can diffuse easily through the dentinal tubules, which are exposed, resulting in apical periodontitis and external inflammatory root resorption. Because the dentine is exposed now, the RGD sequence is exposed, the odontoclasts can attach themselves to the root surface and start the resorptive process. And this process will continue because of the continuous stimulation by bacteria and the infected pulp. Now, it's the most common form of root resorption after luxation injuries and avulsion. Almost 30% of teeth that had an avulsion will undergo external inflammatory root resorption, and around 15 to 18%, 5 to 18% of teeth that had luxation injury will undergo external inflammatory root resorption. The resorption itself, it's asymptomatic, so often it is subclinical unless the infected necrotic pulp resulted in an acute inflammation of the periapical tissues, resulting in swelling, tenderness to percussion, mobility, and abscess formation. If this process left untreated, it can resorb the tooth or the root in months, so it is very progressive. On radiographs, it is an incidental finding, and depending on whether the process is inflammatory or sterile, then the presentation on radiograph will be different. So let's have a look at the sterile external inflammatory resorption and the infective external inflammatory resorption. What we mean by the sterile inflammatory external root resorption or the pressure-induced resorption is the resorption that takes place usually after orthodontic treatment as a result of excessive forces on the teeth, or as a result of an impacted tooth that exerts pressure on the other teeth, or a cyst or a tumor that exerts pressure on the roots of the teeth. You will see shortening or blunting of the root apices, so the apex of the tooth will be rounded and blunt. You will see a radiographic evidence of the causative pathology, for example, an ectopic tooth or a tumor or a cyst. The teeth will be asymptomatic, and usually the teeth are vital. However, if the pressure was severe enough to interrupt the blood supply to the apical, from the apical foramen, then the pulp will become necrotic, but the necrosis will be sterile. So unless there is a crack or caries in the crown of the tooth, then bacteria can gain access to this sterile necrotic tissue, and then the pulp will become necrotic and infected, okay? And apical periodontitis will develop. So in this example, you can see the ectopic canine putting pressure on the central and lateral incisors and causing sterile inflammatory external root resorption. How can we manage the sterile inflammatory root resorption? Obviously, by removing the source of the stimulation. We have to remove the impacted tooth or the cyst or the tumor, or to stop the orthodontic treatment, for example. If the if the stimulus is removed, then this process will stop, okay? On the other hand, in the infective inflammatory external root resorption, it is usually a result of the trauma, as we discussed earlier, luxation or avulsion, which resulted in pulp necrosis and infection. You will see irregular cavities and changes in the contour of the root surface, and you will also see corresponding radiolucency in the bone. So this is how to differentiate between the infective inflammatory external root resorption and the surface resorption. The surface resorption, you will just see change in the contour of the root surface. However, the lamina dura, the bone, the periodontal ligament space will all be normal. However, in the infective inflammatory external root resorption, you will see that there are concavities or cavities in the bowl-shaped resorption cavities in the root surface with corresponding resorptive defects in the bone itself, and the lamina dura will be lost, and the periodontal ligament space will be wider than in the other normal areas. You can see these resorptive cavities anywhere on the apex of the tooth where the apical foramen is, or on the lateral surface of the tooth if there are lateral canals, or if there are cracks or fracture lines. Okay? So anywhere on the root surface. The tooth is usually not responsive to sensibility tests, the electric pulp testing or the thermal tests, because the pulp is necrotic. Now, we need to manage this condition by preventing it from happening if we can, and by stopping it or arresting it if it already established itself or if it already started. Now, as we have discussed earlier, the infective inflammatory external root resorption is very common in luxation and avulsion injuries. Now, in the incompletely developed teeth in young patients, in the young immature teeth, it's common in avulsion and intrusion with crown fracture. However, in the fully developed teeth, avulsion, intrusion, lateral luxation with crown fracture, and extrusive luxation with crown fracture can cause infective inflammatory external root resorption. The immediate management, I'm sure you know by now, will be repositioning of the tooth, splinting, and attempting a root canal treatment, starting a root canal treatment. So to prevent this condition from happening, we need to replant the tooth, repositioning it and stabilizing it with a flexible splint. We need to give antibiotic coverage for the patient to reduce the chances of resorption, and doxycycline is the best. You prescribe 100 milligrams, 2 tablets of 100 milligrams doxycycline on the first day, on the day of trauma, and then 1 tablet daily for 1 week. So doxycycline is the best unless there is a contraindication. For example, if the patient is allergic to it, or if the patient is younger than 12, if the patient is less than 12 years old, then there is a risk of discoloration of the tooth, doxycycline staining. So in these cases, amoxicillin can be used instead. And then we have to do a root canal treatment. We have to start root canal treatment as soon as possible. If we were able to start the treatment on the same day of the trauma, then we have to place a corticosteroid antibiotic-containing intracanal medicament, which is leather mix. And then we place it for a few weeks. We get the patient back. We remove the splint. We complete the root canal treatment, or if we need to start epixification, then we apply calcium hydroxide in the canal until we get a hard tissue barrier, and then we do the root canal treatment. We have to review the patient regularly to assess if there are any complications, or if to check if the external resorption is not taking place, or if it's taking place. Okay. So if you have a patient with avulsion, so you replant and splint the tooth with a flexible splint immediately, and then you give the patient doxycycline coverage for 1 week. You start root canal treatment, you put corticosteroid antibiotic containing intracanal medicament, and then you complete the root canal treatment. This is how we prevent the external infective root resorption, inflammatory root resorption. Now, if the resorptive process has already taken place, or if it's already established, then we do the same but without the antibiotic coverage. So you assess the restorability of the tooth, you assess the extent of the resorptive process, you start the root canal treatment, you apply the intracanal medicament, and then you complete your root canal treatment. You follow your patient up. So antibiotics are not indicated if the resorption process is already taking place. Just a quick reminder, leather mix contains corticosteroid and antibiotic. The corticosteroids will have the anti-inflammatory effect, and the antibiotics will have the antibacterial or antimicrobial effect. The corticosteroid in leather mix is triamcinolone, and the antibiotic is dimeclocycline. Now, the third type of external root resorption is the external invasive cervical root resorption. So, this type of root resorption, uh, it represents an invasion in the cervical area by a fibrovascular tissue derived from the periodontal ligament space or from the periodontal ligament. This fibrovascular tissue will progressively resorb the cementum and dentine and even enamel. Eventually, if left untreated, it will reach to the pulp. It's often symptomless, although the patient can have mild discomfort or irritation from the surrounding gingival tissues. There are different predisposing factors to this type of resorption, but especially trauma and orthodontic treatment and internal bleaching have been implicated, or if they happen in combination, they will cause invasive cervical resorption. So if the patient has traumatic dental injury as a child and needed orthodontic treatment afterwards, and there was discoloration in the tooth, and the patient needed internal bleaching, the combination of these effects will result in invasive cervical resorption. There are other factors or potential predisposing factors. Period treatment, like resulting in damage of the cementum, protective layer of the root surface. Sometimes developmental defects between the cementum and the enamel, if there is a gap and the dentine is exposed, this can predispose the patient to external invasive resorption. Patients who have cats, it's been found that cats have similar resorptive defects on their teeth as a result of a herpes virus, feline herpes virus. Patients who have close contact with cats have been found to be probably more predisposed to invasive cervical resorption. A patient who had maxillofacial surgery or tumor removal, or patients who have impacted teeth that have been extracted with surgery. These factors can cause damage to the root surface and result in external invasive cervical resorption. Clinically, you will see a pink spot if the resorptive process is taking place in the coronal part of the tooth at the cervical area, especially in the labial side. You will see a pink spot, and that's due to the vascular granulation tissue, the resorptive tissue within the resorption cavity. It thins the enamel, and you will see the shadow of this granulation tissue. So a pink spot. And if you try to probe the area, you will get profuse bleeding because this resorptive tissue is highly vascularized. The edges of the cavity will be sharp and irregular, and this will differentiate it from caries, which is soft. You can sometimes find a purulent exudate, which indicates an infection of this granulation tissue. And unless the lesion is extensive and reaching to the pulp, the the tooth will be responsive normally to vitality testing, okay, if the pulp is not involved. Some of these resorptive defects are very extensive, okay, and they cannot be treated, and the tooth would have to be extracted. Sometimes if the resorption is very extensive, it will result in thinning and undermining of the crown of the tooth, and you will see the coronal segment of the tooth is highly mobile. Heithersay has classified the invasive cervical resorptive defects into 4 classes, depending on the severity and the location of the resorptive defect. So if it was just a shallow cavity in the coronal dentine, then this is class 1. If it was a deeper, more extensive resorption in the coronal pulp chamber, or very close to the coronal pulp chamber with no or little extension to the radicular dentine, then this is a class 2. So class 1 and class 2 will only be in the coronal part with little extension into the radicular dentine. Class 3 means that the resorptive defect is extending into the coronal third of the root, and class 4, the defect will be extending beyond the coronal third of the root. This is an example of a class 3 Heithersay external invasive cervical resorption. As you can see that the enamel has been eaten or resorbed by the fibrovascular resorptive tissue. The gingiva is inflamed in this area. On the radiograph, you will see that there is an extension to the coronal 1/3 of the root. The management of this condition is to remove or curette this resorptive tissue. We have to treat it with 90% trichloroacetic acid. The trichloroacetic acid will cause coagulation necrosis of the resorptive tissue and making it avascular and facilitate its removal. It will also burn the remnants of the resorptive tissue that has infiltrated into the dentine. So it has to be curetted and treated with the acid. If the pulp is exposed, then root canal treatment is indicated, then the tooth is restored. This is a class 4. As you can see, the resorptive defect is extending beyond the coronal third of the root. And this is a class 2, which means that the cavity is extending a little bit to the radicular dentine. Now, the success rate of the management of the external invasive cervical resorption depends on the degree or the extent of the resorptive defect. In class 1 and 2, you can get up to 100% success rate. In class 3, you get a 78% success rate, while in class 4, the success rate is only 12%, so extraction can be a better option. So the treatment, as we have said, involves surgical or non-surgical exposure to the resorptive defect and restoring it if the tooth is restorable, while in class 4, Heithersay, then the tooth has to go. There is a condition called transient apical breakdown, which is a trauma-induced non-infective root resorption. It's similar to the surface resorption. It usually happens after luxation injury. On the radiograph, you will see confined periapical radiolucency that will resolve within a few months. The tooth will be responsive normally to vitality testing. Sometimes you can see that the tooth it's getting red or pink, which is just an indication of increased vascularity to the tooth and intrapulpal hemorrhage, and this can also resolve spontaneously without any treatment. However, in 50% of the cases, the discoloration will not go away, giving an aesthetic problem to the patient. If you follow this tooth up on the long term, the tooth will gain again its normal contour, and the apex will close uneventfully. This is an example. A young patient has laterally luxated his maxillary right central incisor. The tooth was repositioned, splinted. After 1 month, you can see that the tooth is darker than the other teeth. On radiographs, you can see there is like a resorptive defect. If you compare this tooth with the contralateral tooth, you will see that there is a resorptive defect on the internal surface of the root. A radiograph that was taken a year later shows that the tooth contour is almost normal. The resorptive defect is not visible anymore, and the tooth has gained its color again. The last type of external root resorption is the external replacement resorption, or what you call ankylosis, which means fusion of the tooth to the bone, to the surrounding bone, and loss of the periodontal ligament. Clinically, often there's no symptoms, but if the ankylosis or the replacement resorption affects 10 to 20% of the root surface, then you will start to see the following. The tooth will lack mobility, so if you try to move the tooth, it will be completely immobile. The tooth may start to look shorter than the other teeth, so there's infraocclusion, especially if the ankylosis occurred in a young patient. If you do the percussion test, you will hear a high-pitched metallic sound. Okay. If you take a radiograph, you will see loss of lamina dura, and you will see that there is no periodontal ligament space, and you will notice that the dentine is irregular or moth-eaten, with bone progressively replacing the dentine. So you won't have a tooth substance, but you will have bone replacing the tooth. This condition is unfortunately progressive, and eventually it will resolve the entire tooth. And unfortunately, there's no means of arresting or reversing this condition. Once it's started, it will eventually result in loss of the tooth structure. The tooth structure will be replaced completely by bone, and the crown part of the tooth will fall off. Predisposing factors include avulsion injuries with extra-alveolar dry time over 60 minutes, or if the patient used water as a storage medium for the tooth after avulsion, the water will damage the periodontal cells, periodontal ligament, and it will result in ankylosis. If you use calcium hydroxide as an intracanal medicament at an early stage after trauma, so immediately after trauma, you shouldn't be using calcium hydroxide. You should be using corticosteroid antibiotic containing intracanal medicament. Calcium hydroxide can be used after 2 weeks or 2 weeks following the trauma, but not immediately. Intrusive luxation can also predispose the tooth to replacement resorption, or if you splint the teeth after trauma with a rigid splint for a prolonged period of time, then this also can predispose the tooth to replacement resorption. What treatment options do we have? So you can see here the maxillary right central incisor is in infraocclusion, and it has undergone external replacement resorption. You can accept the position, especially if the patient has a low lip line, so the margins of the tooth are not exposed. But if the patient has a gummy smile, then this will be an aesthetic problem. Also, you can build the tooth up with a composite just to make it level with the other adjacent teeth. You can auto-transplant, you can extract a normal tooth, for example, for orthodontic purposes, you can extract the premolar and then shape it into a central incisor and replant it instead of and extract the central incisor. You can surgically reposition this tooth, so you can attempt extraction of this tooth or extrusion of this tooth, but this has to be done carefully in order to avoid damage to the coronal tooth structure. Some claim that if you do so, you will break the contact between the bone and the tooth surface, and maybe you can, the apical tissues can heal themselves. Or you can extract and replace with an implant or an adhesive bridge, or you can do decoronation. And this is decoronation. We remove the crown part, we leave the root, we fill the canals with intracanal medicament, for example, calcium hydroxide, and then we bury these roots under the gum, we release a flap, and then we suture the flap over the roots. Decoronation will preserve the width and the height of the alveolar ridge. So if the patient is young and cannot have implant treatment at this young age, you can leave these roots. They will eventually be replaced with bone, but they will preserve the height and width of the alveolar bone. But if you extract these roots, then resorption of the bone will take place, and you may need bone grafting in the future. Okay. Now let's move into the second part of root resorption, which is internal root resorption. This process will take place within the root canal system, within the, on the internal surface of the root. It has been associated with trauma and replantation of the teeth that have undergone pulpotomy or crown preparation, which will result in predentine damage and will allow the odontoclast to resorb the dentine. So in order for the internal root resorption to take place, there should be damage to the predentine. And this damage can occur as a result of trauma or as a result of vital pulp therapy sometimes, or as a result of crown preparation. So when you prepare crowns, this heat generated by the handpiece can cause damage to the predentine and predispose the tooth to internal resorption. Now, in order for the internal root resorption to take place, you have to have vital pulp apically, okay? And you have to have necrotic pulp coronally. The vital pulp in the apical area of the root canal or apical to the resorptive tissue will provide the blood supply and the nutrients for the resorptive tissues, while the necrotic and infected tissues coronally will provide the stimulus, the continuous stimulation. It has three subtypes. The first one is internal surface resorption. On radiographs, it's indistinguishable. It's difficult to diagnose on radiographs. you will see that the odontoclasts would have started the process of resorption, but it arrests. It is self-limiting, no further treatment is needed. It can be discovered only histologically, not on radiographs, and not clinically. The cause of this process is mostly unknown, but probably it can be trauma or infection in the coronal pulp. The second type of internal root resorption is the internal inflammatory resorption. Clinically, the tooth will be partially vital, and sometimes the patient can complain of symptoms of pulpitis. Vitality testing, it's inconclusive because the tooth is partially vital and partially necrotic. Both the internal inflammatory resorption and the external inflammatory resorption may present as a pink spot. However, the histopathology, it's different. The origin of the resorptive tissue is different. If it's internal resorption, then the resorptive tissue is coming from within the root canal, while if it's external inflammatory resorption, the inflammatory cells will start resorbing the root surface from the periodontal ligament side. On radiographs, you will see an ovoid, irregular enlargement or ballooning of the root canal, and it can be differentiated from the external inflammatory resorption using the parallax technique. So, in the internal inflammatory resorption, the root canal itself is enlarged. So, if you take an angled radiograph or radiographs from different angles, you will see that the resorptive defect is centered within the root canal. While if it was an inflammatory resorptive defect, let's say for example on the palatal side of the root, if you take another angled radiograph, you'll see that the radiolucency is moving with you, okay? Another thing that you will notice in radiographs, if it was an internal inflammatory resorption, the resorptive defect will be continuous with the root canal. While if it was an external inflammatory resorption, you will see a circle representing the resorptive defect, and then you will see the lines of the canals overlying the resorptive defect. Okay, so these are two features to distinguish the internal inflammatory resorption from the external inflammatory resorption. So as we have said previously, the predisposing factors could be trauma, vital pulp therapy, or crown preparation. The last type of internal resorption is the internal replacement root resorption. It's very rare. Okay, in general, internal resorption it's more rare than the external resorption. External resorption is more common than the internal resorption. On radiographs, you will see irregular enlargement of the root canal space with diffuse mixed areas of radiolucencies and radiopacities reflecting the metaplastic changes. So there is a metaplasia in the pulp tissue. The odontoblasts and the pulp tissue, it's transforming or becoming bone tissue. Sometimes in advanced stages, this will lead to complete obliteration of the canal space with cancellous-like bone. It can be difficult to distinguish from the external cervical resorption, and sometimes you may need a CBCT. The reason or the mechanism on how it occurs, it's not fully understood. It's not fully understood, so there are some theories. Some suggested that, so if you ask yourself, where do the bone cells come from? How do they invade or get access to the pulp space? Some suggested that the dental pulp stem cells can produce osteoid material as a reparative response to trauma or inflammation or bacteria. So the origin of these cells are from the dental pulp itself. Or some suggested that these cells were not resident in the pulp space, but they migrated with the blood supply from the periapical area, from the periapical bone tissues. So they migrated through the blood supply from the periapical area via the capillaries, and then they become resident in the root canal, and then they start producing this bone. This is an example, so you can see there's diffuse radiolucencies and radiopacities in the root canal, and this is after treatment. How do we manage the internal root resorption with its different types? As we have said, the internal surface resorption is self-limiting and there's no need for treatment. We can't even diagnose it. It's only visible histologically. But with the internal inflammatory and the internal replacement root resorption, we need to remove the stimulus. We need to remove the vital tissue that provides the vital pulp tissue that provides nutrients to the resorptive defect, and we need to remove the necrotic infected pulp that provides the stimulus to these resorptive tissues. So if the tooth is restorable, we have to do root canal treatment, we have to put intracanal medicament in the canal to get rid of the resorptive tissue and to get rid of the highly vascularized granulation tissue within the canal space. Single stage root canal treatment, it's not recommended. It's very advisable that we use an intracanal medicament to disinfect and to remove the resorptive tissue from the root canal. There are certain challenges that you will face while doing a root canal treatment for a tooth that has been involved with internal resorption. The first one, when you access the canal, you will notice excessive hemorrhage from the canal because of the resorptive tissue. It's very highly vascularized. And sometimes if the resorption is extensive, then there can be a perforation of the root surface. Then this has to be repaired with MTA. In cases with replacement resorption, you may notice complete obliteration of the canal, and then you may have to use ultrasonic tips to break down these bony deposits in the root canal. Because of the irregular shape of the resorptive cavity, we have to agitate and activate the irrigants. And then when we do the obturation, again, because of the irregular shape of the root canal after the resorption, we have to use thermoplastic gutta-percha techniques. For example, the warm vertical compaction technique. And this is how, if you attempt cold lateral compaction, this is what you can get. But with the warm vertical compaction, you get complete filling of the irregular resorptive defect. So just a reminder of the different types of resorption, root resorption. This is an internal resorption. You can see ballooning of the root canal. This is an external inflammatory root resorption with corresponding resorptive cavities in the bone and the root itself. This is a replacement, external replacement resorption. The tooth is eaten or resorbed and it is replaced with bone. And this is an invasive cervical resorption. Okay? I want you to be careful when you read your radiographs. Ask about the patient's age, ask about previous trauma or history of trauma, and also have a look at the contralateral tooth. Okay, so in this radiograph, this is not resorption. This is a young patient. The tooth has just erupted and the apex it's incomplete. So this is a normal tooth. We don't need to do anything. This is not resorption. Okay, this is a young immature tooth. Okay, that's still the apex hasn't closed yet. In this case, this was a 25-year-old patient. This is also not resorption because the canal it's very wide. Okay, so when we take history from the patient mentioned trauma as a child, so the pulp became necrotic and the apex is not complete. So it's not an inflammatory resorption, but the apex hasn't completed because of necrosis of the pulp. And again, this is not resorption. This is just a young patient, and the teeth are immature, and the apices has not closed yet. This is just a summary of the on how to diagnose different types of resorption and what results will you get after doing clinical and radiographic examination for the different types of resorption. And thank you for listening.